Now that our circulation assessment and management is complete, we can move on to disability. When we look at the patient, are their eyes open? Are they interacting? Assess the patient's conscious levels, and this can be performed by using the ACVAPU system. This has 5 categories: A for alert, C for confusion, V for voice, P for pain, and U for unresponsive. So starting with alert. An alert patient is someone who is fully awake with their eyes open and will respond and communicate. This also includes asleep patients who maintain an alert state once woken. Confusion. This is a new addition to this assessment. This should be documented for an alert patient who is displaying new confusion. Should a dementia patient, for example, appear confused and it is unknown as to whether this is normal for them, we should treat this as a new episode until a collateral history is obtained. Voice. The patient makes some kind of response when you talk to them. This does not have to be a vocal response, but can be the opening of the eyes or movement of a limb when prompted to do so. Pain. The patient responds when subjected to a low-level pain stimuli. A trapezius squeeze should be used to assess for response to pain. The sternal rub and pinching of the earlobes should not be practiced, as these methods can harm the patient. A jaw thrust is also a good indication of pain responsiveness. Unresponsive, where the patient makes no response at all. Glasgow Coma Scale is a more in-depth assessment, but it is very difficult to perform accurately and quickly in an emergency situation or in acutely ill deteriorating patients. This should be left until after the initial assessment and initial management has been completed. If the patient is either responsive to pain or unresponsive, their airway is at risk of becoming compromised. You will need to shout for help and put out a crash call. We now need to look at the patient's pupils. Are they equal and of a normal size? If they are of an abnormal size, this may indicate a potential neurological problem. Using your pen torch, shine your light into each individual eye in a sweeping motion. Are both pupils reactive to light? Compare the findings between both pupils and note any differences. Pinpoint pupils are seen with an opioid overdose. Misshapen irregular pupils may indicate brain injury and will require immediate investigation by a clinician. The patient will likely need a CT scan. A fixed dilated pupil in the context of a brain injury indicates herniation of the temporal lobe through the tenorial hiatus, known as the coning. This is a result of the third cranial nerve compression and is an imminent sign. Get urgent specialist senior help. A patient's blood glucose level should be recorded. Both hypo and hyperglycemia can cause a reduction in consciousness. A blood capillary glucose can be obtained by performing a finger prick test and using the blood glucose monitoring machine. A patient's blood glucose can also be found on the bottom of a venous or arterial blood gas, should one have been taken. Check the result. Is it high? So is it greater than 15 millimoles? Or is it low? So less than 4 millimoles? Listen to the patient. Are they communicating? Are they coherent? Are they confused? Are they agitated? Can they follow a command? Is their speech slurred? Are they giving you any clues that will help you in your assessment of disability? Reduced consciousness due to a traumatic head injury is usually evident from the history. However, you should always look for signs of trauma which may have been overlooked. Soft tissue damage such as bruising and swelling should be looked for, particularly on the back of the head, which may be hidden from view. Leaking cerebrospinal fluid from the nose or ear is indicative of a base of skull fracture. Typically, an extradural hematoma presents with a reduction in consciousness after a delay or a lucid period following a head injury. The patient's drug chart will also need to be reviewed. Look at the medications that the patient has had. Pay particular attention to any opioids they have taken, as this could be contributing to their altered conscious state. It is important to observe for any seizures. Seizures occur when there is a sudden, uncontrolled electrical disturbance in the brain. It can affect people in different ways, such as their behaviour, limb movements, and level of consciousness. Medications will be required to help reduce and/or stop seizure activity. You must put a news call out if you come across a patient in a seizure. At the end of your disability assessment, ask yourself the following. Do you need help now? If so, what help do you need? Do you need to put out a news call? Now that we have completed our disability assessment, we now need to look at how we may need to manage what we have found. If the patient is experiencing high blood sugars, so anything over 15 millimoles, they will need to be reviewed by the medical team and a stat dose of short-acting insulin should be given. However, if a patient's blood sugar drops to below 4 millimoles, the patient should be treated in accordance with the Frimley Health Guidelines. If the patient is alert and can swallow, they are to be given the glucojuice drink. Lucozade is no longer used due to the reduced amount of sugar in its recipe. If the patient is unconscious and has IV access, then IV glucose can be given. Either 200 ml of 10% glucose or 100 ml of 20% glucose can be given. However, should the patient not have IV access, then 1 milligram of glucagon can be given intramuscularly. These can all be found in your clinical area's hypo box with a flowchart on the lid for reference. If your patient has reduced consciousness due to opioids, you will need to monitor their airway and breathing closely due to the serious detrimental effects on the systems. As the consciousness is affected, the patient's airway is at risk. They may no longer be able to safely maintain it themselves, and you may also see respiratory depression as the opioids cause a reduced respiratory rate and depth, for example hypoventilation, which will eventually affect both the oxygen and carbon dioxide levels in the blood. Any drug-induced disability should be reversed using the appropriate medications. For opioid toxicity, naloxone should be administered. Naloxone is designed to rapidly reverse the effects of opioids. It binds to opioid receptors to block and reverse the effects of opioids. However, it is important to note that naloxone is short-acting, so the patient may only respond to these treatments for a short period of time. Should this occur, you may be required to give further stat doses. Should your patient have required multiple doses, the medical team may consider starting a 24-hour naloxone infusion. As the naloxone is designed to reverse the effect of opioids, you will need to consider what this means for the patient. If the patient, for example, has been taking morphine sulfate regularly for chronic pain, alternative pain relief will need to be sought and given. The duration of naloxone is 45 to 70 minutes and has a very short half-life. Therefore, respiratory depression from opioid overdose may persist longer, sometimes up to 4 to 5 hours after the overdose. However, this may last longer if their renal function is diminished, for example, in patients with chronic renal failure. Therefore, the clinical effects of naloxone may not last as long as required, and an infusion may be indicated after the initial rescue doses. Close monitoring of the patient in an appropriate designed high dependency area is required whilst the effects of the opioid overdose wears off. This graph demonstrates how the naloxone interacts with morphine. You can see that, due to its half-life, it is very short-acting. Therefore, the patient may require more doses depending on how much opioids is in the system. You may want to think about what other medications you have in your clinical areas and do you know the antidotes for them. Now we will have a brief look at the management of seizures. If your patient is having a new seizure or their seizure is lasting longer than normal, your initial treatment will be to shout for help and put out a crash call. Seizures can be unpredictable and there is a chance that the airway can become compromised. Therefore, you will need expert help to hand. During a seizure, you need to maintain the safety of the patient. Place them in the recovery position and protect their head. You are to time and document the length of a seizure on the TRUST seizure chart. Administer 15 litres of oxygen via the non-rebreathe if their SpO2 levels drop below 94%.